Welcome. My name is Tom Nguyen. I'm the Chief of Cardiothoracic Surgery at UCSF in San Francisco. And it's a pleasure to be joined by Dr. Jo Chikwe, a good friend down the street from us in Los Angeles. She's the chair of the Department of Cardiothoracic Surgery at Cedars-Sinai, and also the editor of one of our major journals, the Annals of Thoracic Surgery. We want to discuss an important trial that recently was published and presented at the ACC 2023. And it's a topic that's very near and dear to our hearts, no pun intended, but essentially the trial looked at randomizing patients to minimally invasive versus sternotomy surgery in the United Kingdom. As a very broad overview, there's a lot of debate between what's the best approach for patients with mitral regurgitation that need mitral valve repair, whether they should get a sternotomy or a minimally invasive approach. And a lot of questions about the minimally invasive approach. Can you repair as many cases? Can you repair them as well, or if it's safe? So this is a huge trial. It's actually one of the first large multi-center randomized trial in the UK and reality in the whole world. And what the authors found were actually pretty interesting. I'll start off with a little bit of the background of the trial. About 1,100 patients were initially evaluated. 330 patients were randomized, about 164 in the sternotomy arm, and about 166 in the minimally invasive arm. They looked at functional status after surgery from baseline to 12 weeks, and essentially they found that there's no difference in functional status. But what they did find was the functional status improved a lot faster with the minimally invasive approach. So in patients with the minimally invasive approach, from baseline to 6 weeks, they recovered a lot faster. As expected, or maybe not so as expected, patients in the mini group had reduced postoperative length of stay. They were discharged earlier. Both arms had super high repair rates, about 96%, with very little residual MR at 1 year. And then lastly, when we looked at outcomes, death, heart failure, reoperation, both are pretty similar. I wanted to engage in some discussion with my colleague, Dr. Chikwe. What does this mean to our patients, and what does this mean to our providers? What's your interpretation of this trial?
I think that some of the aspects of the trial really highlight the importance of experience expertise. I think although that we're really focusing on the fact that there wasn't a significant difference in the primary outcome measure of essentially quality of life at 1 year, some of the things that struck me was the actually surprisingly high mortality in the trial and the surprisingly high replacement rates in the trial. When we look at STS national data for the US, most recently published in JACC and the Annals of Thoracic Surgery, over an 8-year time span, the mortality of mitral valve repair in the US for most centers and most surgeons across an all-comers national database was 0. And obviously it's not 0, but if you look at every single patient that had a degenerative mitral valve repair in the US, the average mortality is less than 0.3%. 90% of patients can expect a mortality of less than 1%. And I think comparing that to the outcomes in this trial, which, good surgeons at good centers had, 1 death out of 166 patients in the mini thoracotomy arm and 4 deaths out of 163 patients in the sternotomy arm. That's 2.5% operative mortality overall in a relatively low-risk cohort. And 8 patients in the mini thoracotomy arm and 5 in the sternotomy arm got replacements in a selected degenerative cohort. That's an interesting snapshot of practice. So I think my first take home is that I think certainly for patients in the US going to experience centers, you can actually expect much better outcomes. And I would ask the question, does that maybe translate into a greater benefit that our patients receive at these expert centers if they're having minimally invasive approaches that maybe this trial wasn't really powered to define?
That's a great point. So the trial actually did try to make sure that the surgeons were experienced, and one of the criteria was that the surgeons must have completed at least 50 procedures prior to surgery. And you and I know 50 operations, mitral surgeries before, really isn't a whole lot to be an experienced mitral surgeon. And then they divided the surgeons that did sternotomy versus minimally invasive, and maybe not surprisingly, the number of operations performed prior to surgery was higher in the sternotomy group, about 162, versus in the minimally invasive group, 86. And then they looked at the number of years surgeons had practiced. And in the sternotomy group, the surgeons have been practicing for at least 14 years. And interestingly, the surgeons in the minimally invasive group, 7.5 years. So just as some background and some context. Joe, you brought a really interesting point. So you point out a discrepancy, a potential discrepancy in the repair rates and the outcomes, maybe in the SCS database, and also from this trial, alluding to the fact that the outcomes might have been a little bit worse in this trial. Do you think that, what's the real answer? Is it the data from here, or is it from the US SCS database, or how do you reconcile this difference?
Well, I think it's impossible to reconcile a national all-comers database with a carefully selected randomized trial in expert centers. One would hope that the carefully selected randomized trial in expert centers shows you best practice. So certainly that tells you a lot about what can be achieved in terms of mortality and replacement in the setting of low-risk degenerative patients. I think that certainly the take-home from what can the average patient expect, certainly in the US, is an extremely safe mitral valve repair procedure if they're going for mitral valve repair. But the broader concern about replacement rates for degenerative patients in the US, which is answered in data looking at essentially repair versus replacement in these degenerative patients, suggests that the US still has a ways to go. For an isolated P2 prolapse, still have a 20% chance across the US of coming out with a replacement. That's slightly older data, but again, it's all comers. In expert centers, that should be 99.5%. So I think that the American Heart Association has gone a long way to try and adjust this by identifying mitral centers of excellence where patients can be assured of not only high repair rates, but because we all have to submit our echoes and post-operative follow-up to be recognized as one of those centers, they can be assured that the freedom from mitral valve regurgitation is good and the durability of those repairs are good. And that's only capturing about 26, 30 centers in the US right now. I think we've really got a duty to try and expand that so patients have access, cardiologists are very clear where they can get the best outcomes. And that's the first part of trying to improve the patient experience. And the second part is, can the same quality of care be achieved through a much less invasive incision? And the reason this is important is because I think transcatheter modalities for effective mitral valve repair have improved to the extent that we really have to be able to provide a compelling reason why a patient would undergo an incision of any kind if a MitraClip or a Pascal device can achieve mild or trace regurgitation with long-term durability.
I want to highlight something that you mentioned I think is super important. These randomized trials are very selective. The trial started with 1,100 patients, and most of them got screened out for whatever reason, and ultimately their population was 330. So a lot of times we look at randomized trials as a gold standard, but I think us as physicians and healthcare providers, we always have to go look at the data and look at what patient population we're being looked at and see if that fits into whatever patient we're looking at to interpret this data and apply that data to. So you mentioned transcatheter. When or if or should we ever have a transcatheter randomized trial, transcatheter TEER versus minimally invasive versus sternotomy? Is that possible?
I think that a three-pronged randomized controlled trial just raises so many methodological challenges. And really the key question for folks is, should they be having a surgical repair or should they be having a transcatheter repair if they've got degenerative mitral regurgitation? And there are three trials in this space. There is obviously a very high-risk patient cohort trial that is close to randomization based in France, which is MITRA-HR. There's the Abbott-supported repair MR trial, which is really looking at intermediate risk patients, which represent less than 15% of practice today. So that's an important cohort of patients, but it's certainly not the majority. The majority of patients undergoing any kind of procedure for degenerative MR are low-risk patients. And the primary trial, that's an NIH-funded, investigator-initiated, pivotal randomized trial, is looking at that majority group of patients with long-term outcomes, a very stringent composite endpoint. And I very much hope that's going to give us the kind of data that really informs the conversation that we're already having with patients in our office. If you're sort of over the age of 60 and you've got a P2 prolapse, are your outcomes short and long-term going to be better with surgery or TEER? Frankly, the approach, I think, is important to patients. I think the UK trial shows us that there's not a big loss whichever approach you go. So the key thing now is to really choose your modality and choose your surgical or transcatheter program with care to get the best outcome.
And as we wrap up, I want to ask two more questions. The first question, you mentioned transcatheter and surgery, but surgery, as we know from this trial, there's two ways to do surgery. We could do it minimally invasively, or we could do a sternotomy. So from this trial and from your experience, if someone needs surgery, should minimally invasive be the gold standard?
Well, that's a really unfair question to ask. Like, you're a minimally invasive mitral surgeon. I'm a minimally invasive mitral surgeon. I think the only thing that we do differently is I use a robot and use direct vision, and we both get great results. And we also know that the results in our hands are, at least as good, if not better than sternotomy approaches in many hands. So I think the key thing is that patients have access to the right information and hopefully access to great programs that can offer them either. Certainly, I'm very comfortable telling patients they should be out of the hospital in 3 or 4 days. They should be able to drive, go on a flight, get back to normal within a couple of weeks. It's really a compelling option for most of them.
And as we wrap up, I wanted to get your thoughts for the audience out there. What kind of follow-up study do we need or should we expect after this trial? What's next? Should we have a larger randomized trial out there? Should we look at a different patient population? What's the follow-up to this study?
I think that the follow-up to this study is going to be great to see longer term outcomes. That said, I genuinely believe that the focus for us as a cardiac community is really understanding which patients are best suited to a transcatheter approach and which are best suited to a surgical approach. And that surgical approach has to be a 99% repair rate with great durability and an excellent functional outcome.
Joe, thank you. It's always a pleasure talking and learning from you. I appreciate your time. I want to thank Medscape again for hosting this really important discussion on this landmark trial, comparing a question that we debate all the time at our surgery meetings and that's discussed at the cardiology meetings. And then lastly, I want to congratulate the authors for really putting this trial together and helping us answer some important questions. Thank you.